Welcome everyone to the CTSNet webinar on the guest editor series, Operative Management of Hypertrophic Obstructive Cardiomyopathy, Gold Standard for Septomyectomy to Stand the Test of Time, curated by guest editor Edward Quintana. Thank you for joining us. Please note this webinar is being recorded and will be available Monday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce CTSNet guest editor and moderator of this webinar, Edward Quintana. He is consultant cardiovascular surgeon at Hospital Clínic de Barcelona and the director of cardiovascular surgery residency and fellowship programs there. He is also an associate professor of surgery at the University of Barcelona Medical School. Welcome, Edward, and I'll turn it over to you.
Thank you, Chris and Mary, and thanks to all the CTSNet staff behind this special issue. Also, I want to thank the CTSNet editorial board for offering this opportunity. We are at an exciting moment for patients with hypertrophic cardiomyopathy, as all aspects of care continue to improve at great speed. This disease has a prevalence between 1 to 100 and 1 in 500, thus affecting around maybe 15, 20 millions of individuals worldwide. And importantly, 2/3 of these patients are thought to have obstruction. What it was once a disease with perceived dismal prognosis is now a condition for a substantial proportion of patients with normal lifespan and eventually enjoying also normal or near normal lifestyle. For obstructive patients with symptoms refractory to medical treatment, myectomy continues to serve as the gold standard invasive treatment and holds the potential to reverse heart failure symptoms, and again, in most patients, a return to normal activities and quality of life. This operation has a track history of above 60 years, but has evolved along the way towards a more extended resection, and more recently, additional LVOT interventions have been added to maximize the hemodynamic benefits. Although at times very complex when care is received by expert teams, this operation is now one of the safest open heart operations with a less than 1% risk of death, possibly less than 2-3% risk of pacemaker when preoperative conduction is normal, and residual obstruction is infrequent with a risk of 1, maybe 2% of need of repeat intervention. So this is a cheap and highly effective operation. Unfortunately, these outcomes are only reproduced by a few centers worldwide and rely on a very experienced physicians and teams. This leaves the majority of patients and systems with an unmet need of potential operation that is truly life-changing. This series we have created are another attempt to increase the visibility of the disease, expand the knowledge, and to positively impact the care of patients further. So we are delighted to count with the presence of an elite panel that have dedicated their professional careers to advance the care of patients with HCM, have led the field of HOCM, and trained the next generation of physicians dealing with these patients. They have contributed to the CTSNet special issue on operative management of hypertrophic cardiomyopathy with terrific lectures that I encourage those of you that have not reviewed to go through them, as you will enjoy and learn as I have done. We have different colleagues here. We have a panel. I think Dr. Martin has joined also. Yes, we have 2 top clinical cardiologists in the field. They both understand better than anybody in an unbiased way the benefits of different treatment modalities for HOCM patients, from medical management to alcohol septal ablation to septomyectomy, and their opinions and insights for this discussion today are a must here. If I may introduce them, I'll start with Dr. Milind Desai. He's the Director of Hypertrophic Cardiomyopathy Center at the Cleveland Clinic. He's Director of Clinical Operations of the Robert and Suzanne Tomczyk Department of Cardiovascular Medicine at the Seidel and Arnold Miller Family Heart, Vascular and Thoracic Institute at the Cleveland Clinic, and he's a professor of medicine at the Cleveland Clinic Lerner College of Medicine, Case Western Reserve University. As most of you may know, he's also the national PI of the recently released Valor HCM trial. And we thank you very much for your contribution with your lecture and also for joining here today in this webinar. Then we have, Go ahead.
Thank you very much for the invitation, and I look forward to this engaging conversation. Thank you again for everything you're doing.
The next one is, most of you also will know him, is Dr. Martin Maron. Dr. Maron is also a world-renowned cardiologist in the field of HOCM and HCM, and is currently the Director of Hypertrophic Cardiomyopathy Center at Lani Hospital. He also has written extensively in HCM and is a co-author of the latest AHA ICC American guidelines on HCM. Thank you for joining today and for your presentation also. we very much value this.
Thanks very much, Eduardo, for the opportunity here. So great to see this being put together and being able to deliver these really important messages about this incredibly important treatment option for patients with obstructive HCM. So thrilled to be part of it. Thank you.
Thank you. On the surgeon side, we have leaders in the field of HOCM, some of them with thousands of operations to relieve obstruction in their backs. The level of expertise that they concentrate in this complex operation is probably unmatched. We are delighted to have here Dr. Nicolas Medira. Dr. Medira is a consultant cardiovascular surgeon at the Cleveland Clinic, where he serves as the surgical director of Hypertrophic Cardiomyopathy Center. He also has one of the largest individual experience in septomyectomy in the world and has published extensively on techniques and outcomes of surgery for these patients. He also has mentored a great deal of surgeons with very active myectomy programs. And thank you, Dr. Medira, for being here. I know you are tight in your schedule.
Yeah, that is the page that they're ready for me. If I could bump Marty, if it's okay with that, that would be great once the introductions are done. And then at least we can chat about my video. And again, it was a pleasure to participate. Thanks for the invitation.
Thank you very much. We have also Sami Said, consultant cardiovascular surgeon, associate professor of surgery at the Masonic Children's Hospital. Dr. Said is well known to all the CTS followers. He has a complex and varied practice addressing from neonates to the elderly. And Sami also has a great experience and training in HOCM and has provided a lecture on strategies for unroofing coronaries in HOCM. Thanks for your lecture and for being here.
Thank you, Edward. It's a pleasure to be here among this great panel to discuss a very fascinating disease. Thank you.
And last, we have Patrick Myers. He's a consultant cardiovascular surgeon at CHUP Cardiovascular Surgery in Lausanne, Switzerland. He has been appointed recently Secretary General of the EX, and Patrick shares with all of us a special interest to advance the care of patients and the quality of surgery for HOCM. Along with Carlos Mestres and some other friends, they have organized a beautiful roundtable on how to start the myectomy program that you can watch in this special issue. Thanks for being here.
Well, thank you. And I want to thank you, Edu, for putting this team of experts together. I'm more here from the CTSNet board and editorial committee. And thanks for taking on this guest editor series and moving forwards and getting more awareness on the field of surgical management of HOCM.
Excellent. Nick, you want us to go ahead with discuss a little bit your talk, or you prefer to leave it for later?
No, if you could do it now, then I'll run off to the OR. I don't want to keep the OR waiting.
Let's go straight to the deal then. I have to say, Nick, that some residents in the recent days have expressed their gratitude in the lecture that you've put together, explaining the anatomical landmarks and correlations to guide the resection in septal myectomy with your 3D model, very didactical. It's been great. So the first question that I have for you is whether these 3D models may help, the new guys engaging in this complex operation, whether you think that has a value and a role. What do you say to them?
I do. There's been a couple of presentations at various meetings about using 3D models and practicing resection. And that was a handful of years ago, and it was expensive to build 3D models, much less expensive to do it now. And, to my surprise, and I haven't used it much, you saw in the video, the color coding you can do, the CTA and what you can do to try and identify where things are, correlate it to your imaging that you have preoperatively in the MRI and the echoes, I think will be invaluable. And as you mentioned, I've done quite a few myectomies, but looking at the model from the apex through the aortic root really, really brought the sort of the anatomy of the septum into a perspective that I didn't really have after many years of trying to put it all together in my head. So I think it would be very, very helpful, especially if you have somebody with some experience that can walk you through it. It's so hard, even with a camera on your headlight, for the residents or fellows to see exactly what you're doing as you're trying to point out the structures in the operating room. So yeah, to answer your question, I think it'll be very helpful.
That is great. And beyond that, I mean, I think we all sometimes struggle with resections, you know, in patients with deep chest, small annuli, sometimes rigid roots. Can you give us some hints to the audience on how to improve visualization to make sure we get what needs to be taken out during this operation?
Yeah, there's a couple of tricks. Serendipitously, in a patient that had coronary disease, I found that, you know, once they took the mammary down and we had opened up the pleura, if you can get the apex to drop as posteriorly as possible, that really helps. So if I'm really struggling, sometimes I'll open the pleura when I don't need to, and I'll make sure they deflate the lungs so that the apex drops as much as possible. In one of my prior surgical videos, I showed that having a flattened sponge stick that looks sort of like a spatula, something flat where you can put it, generally it seems to be right along the LAD distribution, and press the LAD anterior wall towards the apex. You can bring the septum into view. And the key is to have it so when you're pressing, you get the sense you're pressing down and bringing the septum in a way that it's pushing the septum between the papillary muscles. You can spin the septum, obviously, if you're pulling that sponge stick, you know, towards you or away from you, and then that distorts what septum you're trying to cut. But if you push it generally straight down, that keeps the center axis of the septum in line with what you're trying to visualize, and helps you. So it allows you to get all the way to the apex. With a little bit of practice, you can bring the apex into view by using this sponge stick and a malleable. The malleable I use is very specific. We tried many different gauges of steel to get the right malleable that bends enough, but doesn't bend when you're pulling hard on the septum. And it's 0.050 gauge steel. And we tried multiple gauges of steel to get the right one that works. And so with the right instruments and a sponge stick, you can see all the way to the apex.
Great answer, great tricks. Now I'm gonna ask you something on provocation. I think you and me have talked sometimes in the past about that. And you know, after reset, I think that's a hot topic, and I still don't know the answer. Because of course, you know, when you do a myectomy and you look satisfied at the end, you go and challenge the patient sometimes or sometimes or more often than we used to do in the past with inotropes. You know, the level of provocation that we can try to use to unmask obstruction is, you know, I think still under investigation, because if we were to stress all the mitral valve repairs that we've done for the degenerative disease, some of them we probably need to redo things or maybe replace the valve. So what's the level of inotropic doses that you would advise practitioners to use early after this repair in the OR? And how would you react to that?
Yeah, great question. So I think it's a understanding and evolution, but for a straightforward myectomy, the person really has hypertrophic cardiomyopathy, a 20 millimeter septum or 23 millimeter septum, no other pathology, pretty normal mitral valve looking. I use 10 micrograms of isoprel. The pump is running at 999. It's going in as fast as possible. And I try to have the maximal heart rate. I tolerate a systolic blood pressure of 70. And it definitely avoids finding obstruction in the postoperative period as the heart recovers. So in a young person who really has hypertrophic cardiomyopathy, I think you need to do this. Now, if somebody is 80 and you're trying to just make sure it's okay and you don't have a lot of septal thickness, do you really need to maximally provoke? I'm not sure. So I don't go crazy in that regard. I tolerate a maximal provocation velocity of up to 3 meters per second. So if it's under a 36 millimeter gradient, I accept it, somewhere in that range. But if I get a 64, I will go back and do something more, because my experience has been if I leave that, invariably the post-op echo shows some degree of provocable obstruction. So that's my tricks right now. Now, is it overkill? Maybe, but you avoid the young patient having residual obstruction.
Yeah, I agree for sure. If you do this sort of testing, this sort of aggressive testing, and you don't get obstruction, you know that the patient is going to be perfectly fine. He's not going to require anything down the road. But it's a judgment call where the limits are. I don't know. I welcome the comments from our two cardiologists here to gather your insights on that. It's not easy, right?
No, I think, look, but it is the right thing to do because, once the patient once you close the chest, it's an incredibly difficult conversation on post-op day believe me, I've rounded on the post-op surgical service and trying to dance around that question, why do I have a gradient? It is incredibly difficult. So, Nick has been very good at doing this, and the results speak for themselves. Is, once he's confident and once things, for the vast majority of the patients, there is excellent results, and that is because of all the upfront work he's doing.
I'll just add, Edward. Yeah, I'll just add. I mean, I think we try to keep it simple, coming off in terms of assessing the operation in the operating room. We increase inotrope. So we challenge patients after surgery, when the operation's done, we challenge patients by increasing heart rate and increasing contractility to a reasonable level, pretty similar to what we did usually in provocation before surgery. So increase contractility. We just try to get the heart rate up to 100, 110 beats per minute, enough to be reasonable in assessing the relief of gradient. So you've demonstrated with that kind of contractility that there is no mitral valve septal contact. Gradients, therefore, are less than 30 millimeters of mercury. You can help confirm that by color flow. There's no turbulence, or very little turbulence in the outflow area, and that mitral regurgitation is minimal. And then we stop. And so that's yeah.
So one of the things, and I don't see Hartzell, I could have asked him this question. I was going to ask. So, like Marty said, at our center, we rely we rely on transesophageal echocardiogram to assess for the success of the operation. But there are some alternative practices where they also measure invasive hemodynamics intraoperatively. Nick, why and why not?
I haven't done it. I know I've read the Mayo papers that they have. When you have really, high quality, good cardiac anesthesiologists who are good at transesophageal echo and know that they have to do a transgastric view and get a view across the outflow tract that's not contaminated by any mitral regurgitation signal. And you can see a great signal coming. You can see the turbulence. I think you can reliably evaluate outflow tract obstruction. Right. I think Marty's comments are spot on, but from the surgeon's perspective, the thing that is apparent for all of us who do cardiac surgery is, you can do a myectomy and be done in 20 minutes. It may take you 45 minutes of cross clamp. And then you get this boatload of air that comes through and the RV goes up and down and the EKG changes. And while there's no segmental wall motions abnormality, it's apparent the heart is not fully up and running. but it looks sort of normal and you got a normal blood pressure. And it's my sense that hypertrophic cardiomyopathy patients, some of them with really significant disease, simply don't like much ischemic time. And so if you have a fair amount of ischemic time, even 45 minutes, the wall motion looks normal, but the heart function is not up to speed. So that's when, you know, really driving it with isoprel or an inotrope, I think is critical to fully assess. And the other thing I think about is if you have an 18 or 20-year-old patient that's undergoing a myectomy and you calculate what their maximal predicted heart rate is, it's well above 100. I mean, it's 200. Now, we may beta block them and they're not going to get there, but they're going to get to, I mean, I still get to 150 and 160 when I'm exercising, and so will they. And so if you're really pushing to see how is a 20-year-old who wants to go out and run around afterwards, and it's going to get a heart rate of 150, 160, I think getting a heart rate of 100 in that patient is just simply not enough to say that this person is it. And especially if you look at the outflow tract and it's a little bit narrow. So you push, I push it really hard. So I know when I look at this 22-year-old or 25, whatever, to say, you're not going to have obstruction. Right? Just that to me is the gold standard of walking out of the operation. If you're going to do a myectomy, to me, we're obligated to make sure. In an 80-year-old, different story. They're not going to get that high.
Sami, you want to add something? You also train at Mayo. We're trained with the needle assessment, which I think I personally also stopped doing it as I rely completely on our echo guys. Want to comment on that?
I think these are great points, and it depends on how much experience an echocardiographer or an anesthesiologist will have with the TEE. But I have been in situations where the TEE will say there is a gradient, and by direct measurement there is no, and otherwise there is no gradient, and we do the direct measurement, and there is a dynamic gradient. There is no gradient at rest. And in these cases, I will go back on and take more. So I think that we all agree that the patient should not leave the operating room with any significant gradient or provocable gradient. To me, because I trained at Mayo and I trained under Dr. Schaff, I mean, I pretty much follow his guidance about how to do the myectomy, and the direct pressure measurement, I still rely on it in a lot of patients, especially in children as well, because there's a lot of fallacies that we can get on a TEE in a child. The other point is that's very important for patients who are coming to the operating room with latent obstruction from the beginning. So they don't have obstruction at rest. And you want to really stimulate that post-operative and post-bypass to make sure absolutely there's no gradient with exercise. But I agree, I think there has to be some sort of comfort level with who you're helping and who's helping you to eradicate this obstruction.
Thank you, Sami. But you would probably all agree that with that levels of aggressiveness in provocation, you may overdo things. You may end up replacing mitral valves. Sometimes that may not need to be replaced even. Or if you were to do that in mitral valve repair cases, no HOCM cases, that would be a disaster for many practices around. Don't you agree with that? 20 mics of the glutamine or 10 or the levels of high suprel you mentioned, Nick, maybe, I mean, I get it. If you don't have obstruction, it's perfectly fine, but we don't just simply get the cutoff.
Yeah, well, you're right. I haven't experienced that. Now, when I have patients, I've had recently, just I think randomly, had a run of patients with predominantly mitral valve pathology in SAM with mild septal hypertrophy, 15 millimeters, a P2 scallop flail, very tall leaflet. And I know we're not talking here about mitral interventions, but I've gone from using neocordae back to doing sliding valvuloplasties. And so maybe it's a 2-gram myectomy. They've been a 2 or 3 gram myectomy because there wasn't much hypertrophy and an aggressive posterior leaflet sliding valvuloplasty with a maximal size annuloplasty band, not ring. And then when I provoke them, I do it the exact same way, you know, and it's been interesting to see that there's been no obstruction. And I think the whole idea is if you can get the coaptation point very posteriorly and still maintain appropriate coaptation, you can do maximal stressing and you won't have outflow tract obstruction. I think in our standard mitral valve repair operations, you could generate obstruction if you push it. I've only done a handful of these, so I don't know if what I'm saying is going to hold up with time. But I've stressed those cases exactly the same way, and it's been effective. But you're right. There's the potential that we would generate false positives and end up with mitral valves, but that hasn't been my experience. But it's a potential to happen for sure.
And
also,
and you know, in our experience, Nick, you know, your point is validated by longer term data. In our myectomy, like not mitral valve repair, like the robotic, not that practice, but our myectomy practice, the number of people with advertent or inadvertent mitral valve replacement is incredibly low. It is well under 5%. And we do a fair bit of atypical like OCMs without significant hypertrophy. So we still manage to save the mitral valve in all its glory.
Hey folks, I hate to say it, but I got to run to the OR. I really apologize. I wish I could hang because this is a phenomenal discussion, and I'll have to look at the video. But again, thanks for the time, and Marty, thanks for letting me jump ahead. And then I hope to see all of you soon in one of our upcoming meetings.
Thank you very much for being here. Good luck with the operation.
Hey, Carlos, hello. I just got to say, I got a shout out to Carlos. How are you? Nick says hello.
Yeah, do that. He's listening.
And Edward, for another thing, I think there is a big part of this that depends on the surgeon judgment and experience, because you know that you've got everything resected and you've gone down to the as low as you can to the ventricle, and you know that there's, you know, you enlarge this area, most likely you've done a good job and there's no obstruction. You know, as you know, you can create obstruction even in normal hearts by isoprel, and especially in young patients, etc. So it's important to differentiate that from true obstruction.
So true. Well, let's go back to one of the first lectures from Martin Maren, and we can discuss a little bit more on that. Martin, your lecture, we have seen your enthusiasm for this operation, and you have summarized the benefits of the myectomy amongst other therapeutic options for HCM. And you have pointed at the effectiveness and safety of this operation for symptomatic patients. As a great supporter of this option to reverse heart failure due to obstruction, from your talk, can you highlight how effective this operation is, how it compares in terms of safety with other open heart operations, and what to expect after surgery in terms of need for medications, complications, changes in lifestyle, and also, and last, the durability of this?
Sure.
A lot of questions.
Yeah. Well, I could probably summarize in a way the answer to all those by saying to you that when I talk to patients about this therapeutic option for myectomy, I tell them that, in my opinion, there may not be any other procedure, perhaps in all of medicine, not just cardiology, but in all of medicine, that provides such a profound improvement in quality of life and symptoms than myectomy does, period. It's that profound. And the bar, in fact, is that high when done in expert centers. It is an incredible operation. And the point that it reverses heart failure reliably in the vast majority of patients is in fact true. And that durability in terms of maintaining the obliteration of gradients over long periods of time from the surgery has now emerged with data from multiple different centers demonstrating that out from 10 years or more from surgery, these gradients remain essentially zero, and that symptom improvement is also maintained as a result of that. So I think that not only short-term but long-term durability of this operation, based on what we know today, has got to be considered to be excellent, essentially. Obviously, everything we're saying about the operation in a way reflects that reflects the experience of the operation done in expert high-volume centers. I think everybody listening here would all agree about that principle, that when the operation is not done in that way, in a lower volume, less experienced centers, morbidity and mortality are different. But in expert centers, it is now, myectomy is now one of the lowest, if not the lowest risk cardiac surgery procedure there is, with operative mortality 0.5% or less in high volume centers, which is many-fold less than many of the other operations that are commonly done around the world every day. So that is state of the art. It's a high bar.
I'm gonna add to what Marty says. And again, as a non-interventional cardiologist, non-surgeon, that, I completely agree with Marty. If done in the right hands, this is an incredibly gratifying procedure. And, you, the cardiologist, comes out looking like a hero on the other side, and you haven't done anything other than refer the patient to a surgeon. So in the next few days, I forget when so I presented this data, so it's not embargoed, but we've done a prospective study looking at quality of life after surgical myectomy. So not just random retrospective stuff, prospective. And we found about a 38-point absolute increase in Kansas City cardiac summary score after myectomy. So, this was at 1 year follow-up. So take into account after sternotomy patients, it takes 2 or 3 months for them to heal. And so even within 1 year, their quality of life is through the roof. And these numbers, these absolute increases are better than pretty much any other operation. Having said that, it's great. Look, if I have hypertrophic cardiomyopathy that needs LVOT obstruction relief, I thank God I have Heart Cells and Nick's cell phone numbers that I can text them and get on the operation schedule. But there ain't too many of those. So that is another thing that needs to be recognized. And if you end up in the wrong hands at the wrong time, the American data, the national inpatient sample data said low volume center mortality can reach up to 16%. It's hard to sell a 16% mortality to a 35-year-old with obstructive HCM. So this does set a very high bar. I completely agree that this sets a very high bar for anything new, any new kid on the block, be it alcohol ablation, be it radio frequency, be it, the things that are happening in China with RF ablation, whatever, it has to set a high bar. But there ain't enough people who can set this high bar. So that's an important thing. That's why there's always room to increase the size of the tent with available therapies, not just surgery, available therapy, and also increasing experience amongst people who can do it. I'm so glad to see Sameh, who trained, and Edu, you trained under the best of the best, and now you're spreading the torch. So that's what science and progress is about.
Thanks a lot for your comments. That leads to another question, which is in other fields of, let's say, heart valve disease, for degenerative mitral valve disease, we're ready to operate on the asymptomatic because we know that it changes lifestyle, changes disease course. I have to admit, I'm not ready to operate on asymptomatic HCM patients. Let's say, as you were saying, a 30-year-old completely asymptomatic, but a high gradient, like 120, that you know that this will impact long-term. How do you feel about that? Is that something that we'll see?
Well, I think, yeah, I mean, I think that couple points about that. I mean, I think, look, it's certainly tempting idea to, given how low risk surgery is today, to consider expanding the indications for surgery. And then in fact, those indications have been expanded actually. In the recent 2020 HCM guidelines, the idea was advanced that the operation, myectomy, can be considered reasonable in patient groups that it wasn't highlighted as such in the prior guidelines. In what I mean specifically is patients with less advanced symptoms, let's call that class 2, not asymptomatic, class 2, some symptoms, but other morphologic features for which the operation has an opportunity to potentially alter natural history. Patients with really high pulmonary pressures, patients, for example, that are young with really high gradients, patients with big left atrium who are starting to develop symptomatic atrial fibrillation, myectomy and maze in those patients. So there is a increasing appreciation that this operation, given its durability and low risk and the opportunity to alter natural history in some patients, is reasonable to consider earlier than we have in the past. So that's already being advanced. Now, whether that will be extended further to include your reference to asymptomatic patients is a bigger leap. Okay, it's a bigger leap. I think we all agree with that. It's harder to justify, in a way, in all of our minds, operating, even in high gradients, patients that are truly asymptomatic, partly because we don't know which of those will really go on to develop more advanced symptoms. Some of them, some of them may not. We've got patients that live normal life expectancy with high gradients who really are not limited at all. And so without a really better idea about who's going to progress and which subgroups of asymptomatic patients would therefore benefit, I think it's a slippery slope. And so I don't anticipate operating on asymptomatic patients anytime soon.
So, yes, moving to like a class 2A indication, like you've seen P2 prolapse in mitral valve, you got it, you come to a center, you fix it. I think I agree with Marty, that is sort of a bigger leap of faith. Having said that, the earlier operations, waiting till they develop class 3 and 4 symptoms before operating, I think is an older thought process that is rightly being challenged. As you may or may not be aware, we have published data, more than 2,200 myectomies, of which a proportion were earlier. So class 2 indication, or some of these things that have now been adapted into the current guidelines that Marty alluded to, class 2 or high incidence of mildly symptomatic but significant drug intolerance. And so some of those things have been adapted in class 2B indication. And what we've shown is that if the keywords are if done in the right center by the right personnel, the outcomes are pretty darn good and similar to age and gender match population. In fact, I would even say, expanding. So the concept of surgery should not be only limited to surgical myectomy. Surgical relief of LVOT obstruction, if done appropriately, is pretty darn good and similar to age and gender match normal population in terms of the longer term outcomes. So yes, I think rightfully, with expanding knowledge base, expanding expertise base, people are going to expect earlier operations, and I think that's okay. So the class 2B indication in the current guidelines is steps in the right direction. Absolutely.
I'll add one other point. Edward, can I add one other point there?
Yeah,
okay?
very quickly, because we need to move a little bit to another topic, but yes, go ahead.
It's going to be real quick. the guidelines reflected a lot of what we just said between Mill and I in terms of not saying class 3 or 4. We went away from that designation and we went to a description in which patients decide if they feel that their quality of life is impacted enough despite drug therapy, that is enough to consider moving forward with surgery.
And I think that's we do that. All of us, we do that.
Right, we do. That's right.
Yeah,
that's exactly right.
And Edward, if I may say just one quick point, you know, I do believe that in younger patients we should be aggressive. And you know, the word about asymptomatic but having a high gradient, we see this a lot in children actually, because it's impossible to know if they are symptomatic. They're all running around. And why we will treat asymptomatic severe hypertrophic obstructive cardiomyopathy different from asymptomatic severe aortic stenosis.
Right.
Yeah, that's another challenge too, yes.
Yeah, there's more push towards earlier operation on asymptomatic severe AS.
Well, I think, you know, all these things, you know, with improving technology, improving expertise, all these things will bubble up in a natural way, organic way. I think that's the word I'm looking for. There will be an organic evolution towards right indication. I think that's science, that's progress. So, absolutely.
And Dr. Desai, you made a beautiful and comprehensive lecture on imaging. Multimodality imaging is key for the management of these patients. And I think the surgical audience will be asking themselves what they need to get, you know, to prepare for a good operation. Do all the patients need to get an echo, transthoracic echo, and an MRI, and what to do in the absence of these? What is your opinion on preparations for this operation?
So obviously, a well-done surface echo is the most important thing. If I were stuck on an island with nothing other than an echo machine, I think I can potentially learn to survive. But having said that, and you know, it's just not the echo, it's, you know, doing precise measurements, recognizing when precision may be a problem, meaning if you don't have good windows or if the ultrasound beam is tangential to the septum and you may be overestimating, it's recognizing some of these things. And then recognizing, look, my antenna goes up in a symptomatic suspected HCM patient. If the septum is, again, people can argue, you know, 1.5 centimeter, 1.6 centimeter, you know, if it is not greater than 1.8 centimeters, my antenna goes up looking for other scenarios. So what is the mitral valve doing? What is the leaflet doing? How are the papillary muscles reacting? Now I will tell you, the business of papillary muscles and all those things was first, we recognized that when we started doing cardiac MRIs in earnest. Now, my life has come a full circle that our sonographers now recognize these things. We've taught them enough that almost, you know, I hate to say this, but almost always my opinion about that is already made on echo long before I'm looking at an MRI. So, but that's, you know, like life coming a full circle. Having said that, there is distinct role of looking at images, you know, having an understanding yourself, but more importantly, the reason why me and Nick, or in the past, Bruce, or now Doug Johnston, I mean, you know, we work very well is because we can talk the language of images. We can look at the images together and I can pontificate what I think, what is happening in my head so that they know what I'm thinking. Now, at the end of the day, the decision to do something beyond a myectomy or the amount of myectomy is going to be the surgeon's. And this is where the stepwise approach that Nick described earlier comes into play. There are times when I have convinced the patient that you may end up or patients come to see me saying, I think I'm going to need my papillary muscle done. And I may say, it's probably not real. You may, you know, so this, I hate to say this, but there's no one smoking gun that makes you decide. It's a combination of things. Obviously, the septal thickness, the amount of mitral leaflet, how it is interplaying, and what's happening. So the difficult ones, or some of the ones are, how shall I say, the hypermobile papillary muscle. I mean, that's very subjective. And even sometimes I second guess myself. But the combination of echo and MRI typically helps with this. Almost never have I done a CT to look for this if the MRI cannot be done. I mean, I've occasionally done TEs to further understand, but that is only mostly in the context of bad looking images where I suspect in somebody with COPD or whatever, where the lungs are interfering and we are not getting adequate images. That's when I would do a TEE, but that's few and far between. Hopefully that's a long-winded answer that helps. Great insight, yeah, great insight. And I think I was going to ask you something. I couldn't finish this webinar without asking something on MAVA and the recently released Valor HCM trial, as you are the national PI. But I think Patrick wants to ask himself. You and me have written something on that in the past. If you want to go ahead and do it.
We were just talking about indications in the asymptomatic. Now, your outstanding presentation at ACC, mavacamten obviously brings down the gradients, reduces symptoms. Are we going towards a future where many patients will be managed medically and will not reach the criteria for offering surgery? How are we going to find the right balance there between what we can offer medically and what we can offer surgically? Because I think the goals of each treatment are quite different. As Marty showed, surgery is really outstanding at providing an obliteration of the gradient. And in young patients who have a very long lifetime, will they be able to stand mavacamten or other medications that are in the pipeline for longer duration? So thank you very much. Yes, I would. The number of times I've had to answer this question in the last 4 days. So yes, this is. Sorry, look, we had to ask it. Yeah, this is science, and science and evolution have to happen. That's how the world works. Number one. Number two, the important thing here that is acknowledged is that so far mavacamten or the medical therapies, they have been tested in the shorter term. So Valor, it was only for 16 weeks. Of course, there is a long-term extension ongoing to see the persistent efficacy over the long term. The other thing we obviously need to ascertain is the long-term safety. And like you rightfully said, what does a 36-year-old person who's looking at another 50 years of life do in terms of decision-making? Now, look, I've mentioned this before, and I'm gonna say this again. The tent has to get bigger. The choices have to get, evolution brings choices. And then time determines which is a better choice, which is an optimal choice. So the way I look at this scenario is as follows. 4 scenarios. One is there will be a group of patients who are so much better on mavacamten that they may not need an SRT. There will be some who SRT may be right for me, doctor, but it is not the right time for me. Can I put it off for a few more years? That is another group of patients. The third group is there's high risk for surgery. Nick has turned me down and my septal perforator anatomy is suboptimal. So rather than squirt alcohol in a wrong direction and have some downstream, why don't I try this? So the high risk. And the fourth one, the big one that people should be talking about is access. The person sitting somewhere, who does not have access to heart cells or, something that provides less than 1% mortality. There's a serious argument that can be made. Will you choose a surgeon with 16% mortality, or will you choose one of these cardiac myosin inhibitors? And then let it shake out. I think, and more trials, more data is always good. So to me, it is not about this or that. It is always this plus minus that. I said that at the last ACC
take another example. You guys are surgeons. You know, statins never eliminated CABG. Last time I checked, we are doing more statins and we are still continuing to do CABGs and PCI. So it is never this or that. It is always this plus minus that. And we are gonna figure out what are the right patients to do for this versus that. But at this point of time now, you alluded to a question. Should we be giving long-term medical therapy to asymptomatic patients when we don't have long-term safety data available? Probably not, but is there equipoise where we could potentially study this kind of population, say 5 years from now? The answer is maybe, and possibly yes.
I think what would be very interesting will be the survival curves and see if there is a survival advantage with the superior septal reduction that we have with surgery, but that only time will tell. And as you say, that this is not to be, this is an open discussion. And thank you very much for your very detailed answers. I appreciate these enormously. These aren't questions that are mean to be malicious. This is really to open the discussion. Look, and I appreciate it.
This is life. These are the conversations we should be having at every scientific forums.
And with every patient, we will have that very soon, I think.
Yeah, and I think we also, as a surgeons, we have a role in this is to expand our surgical tent also. I will use Dr. Desaiter is, you know, we have to continue to provide the best results. We have to continue to educate others to do the myectomy. And also, we have to also be careful. I imagine there will be a careful selection about who's the right patient for this. So we don't miss mid-ventricular obstruction. We don't miss apical myectomy. We don't miss things that should have been done to surgery sooner rather than later.
Excellent, excellent. If you allow me, I will ask you one question to you, Sami, and one to you, Patrick, and then maybe reply to some of the interesting questions we have, because it's so interesting. We would be talking for one day here. Sami, your lecture on unbridging coronaries for this population. So how do you assess the coronaries before an operation, septomyectomy? And if you find something like this, how do you decide on whether something needs to be done or not?
That's a great question that I don't know if I will have the real definitive answer to it, because
your approach.
We have to be alert about associated problems with hypertrophic cardiomyopathy, because again, as the bar is high, we don't want the patient to come back for an operation. And you know, one experience recently that we also added to the video is you know, a child who had an excellent myectomy. However, there was a long myocardial bridge for an LAD that was missed, and it was not addressed during his operation. Now you're talking about making a decision for reoperation on a child or a younger patient after previous surgery to try to do an LAD unroofing. That's quite of a challenge, because you can, you know, have problems with it, and it's not easy. It's always easier the first time. So that makes us change a little bit the way to think about it. Is, you know, myocardial bridging in general is a controversial topic, and even in the absence of hypertrophic cardiomyopathy. With those who have hypertrophic cardiomyopathy, you have a big number of patients who have some sort of myocardial bridging. Are you going to unroof everybody? I think a larger series say no, but there are important data about mortality for those who have myocardial bridging, especially symptomatic, in addition to obstructive hypertrophic cardiomyopathy. So for me, you know, the usual indication for a coronary angiogram, which has been the standard in these patients, is the age is one factor, or the presence of symptoms. Angina, preoperative, has to make us think a little bit. It's not a common symptoms we see with hypertrophic cardiomyopathy. The assessment that we rely on really is the coronary angiogram, although there are a myriad of testing available, like multi-slice CT, cardiac MRI, SPECT, all these other stuff. But I think to make it simple, be under the standard echo assessment, cardiac MRI, we move to a coronary angiogram with a hemodynamic assessment. Means probably do an IFR or FFR to see what if there is a true obstruction. Because as you can see, there is a big number that you will pick up with myocardial bridging. Some of them are superficial, some of them are deep. I think we have to think about the long segment, the deeper, and correlate this with the patient's symptoms to be able to properly improve their quality of life and meet their expectations.
All right.
And you're about the technique, or I missed that?
No, it's perfectly fine. I think you replied to that. And I'll go to Patrick. Patrick, you as the future Secretary General of the EX, how do you envision the way in which we can promote this operation further? I mean, from EX, from LACES, the ASEAN Association, AAATS, STS, all the surgical societies, how can we do better on getting this operation to more patients?
I think we need much more.
Patrick,
sorry,
before you go, I'm sorry. I have to get off in a couple of minutes. This has been an absolute privilege. I thank you so much for the invitation.
Thank you very much for being here. Great having you. Thanks, Milind.
Thank you, Milind.
Patrick.
So we need more education. As Marty showed in his presentation, this is a vastly undertreated disease. Most cardiologists and surgeons don't see these patients routinely. So we need to improve the education so that we as surgeons know this more. And we need to strive so that all centers, all patients who get managed surgically, get the results from Cleveland Clinic, from Mayo, from Tufts. This has to be a low risk operation. Edu, Same, you trained with the best at Mayo. Not everybody has the time and resources to do that. So actually, I would put this back to the panel and saying, how can we do this? We need to set up a network for training, a network of expert centers, and definitely the associations. I think it's in their interest, and they would definitely be behind developing something like this. Within EACTS, we have a Francis Fontan Fellowship Fund. We haven't developed anything on this. We alluded to it during the roundtable that we had with Carlos Mestres, and we've already gotten positive remarks about that on Twitter. But on the other hand, let's say on a pragmatic standpoint, is that let's say somebody wants to come train with you, Same, or with you, Edu. Even though you're experts in this field, you're not going to have a case every day where you will be able to show a fellow how to do this. So how can we expose our fellows to as much as possible and within reasonable resources? I don't know if the rest of the panel have any suggestions.
I mean, I agree. I always remember
very quickly, please.
In the beginning, Dr. Chef, used to say it's an operation that it's hard to teach. Also, I mean, it's not easy to teach through a small LVOT or in a patient, and also you're having a very high bar. You can't afford any mistakes. So I think it takes time, it takes patience, and definitely volume, as you alerted to, because that's the only way you can catch up quickly on your skills.
Excellent.
One solution would be to have a team of mentors, a group of experts that could come and be proctors for initial cases after an initial fellowship period in a high volume center. But we'll have to work through this out a bit more in details.
And combination of this, in addition to simulation, in addition to all the meetings, the webinars, the 3D models, the things that you can push the limits through it, I think you can achieve success building programs around the world.
Absolutely.
Excellent. And I think we can continue to reply to questions, through the CTSNet website, and whoever wants can contact us directly. But maybe if I can ask you, there is a question here on what's your gut feeling about minimal invasive myectomy? Sami, you want to comment on that?
I think you know, there is obviously there is some publication and there is some case reports kind of published. When we talk about minimally invasive myectomy, I mean, you can look at minimally invasive aortic valve replacement in comparison to a sternotomy. Upper mini sternotomy is one of the approaches. But however, most of the series here are small series. We don't know the follow-up. We don't know the LVOT later down the road. How long was there any recurrence? LVOT gradient, if you look at publications about the technique, how it is performed, completely relying on a transesophageal echo, because you're not going to have access to put the sponge on a stick on the RV and rotate the septum. You're not going to have access to do direct measurement in the LV. So we have to be very careful not to compromise a good operation for what most patients will say, I want to feel better and I don't want to have recurrence. So that's a very important landmark that we have to compare to. The other aspect is the robotic aspect, but the robotic aspect will make you have to go through a transmitral approach. Now, this is a totally different concept that I personally don't believe in it, because we've seen hundreds of myectomies transaortic, and I wouldn't go to compromise the mitral valve if I don't have to. So this is very important. We don't have a long-term data. We don't have a large series that tell us that minimally invasive myectomy is better than standard sternotomy. So until we have this, I think we have to be very careful. The other aspect, we have attempted upper mini sternotomy in some patients, and done the operation through that. And I just remember the first time I did an upper mini sternotomy, and I was helping Dr. Shab doing a myectomy. He told me, "Why do you want to compromise a good operation?" That was it. It was the last time I did an upper mini sternotomy for a myectomy.
Well, it's very hard to engage in new operations when you have a one that really works so well. It's so safe. It's cheap. Plus, the data 30 years down the road, 40 years down the road. It's very, very challenging to risks.
And I think also if you're working with a group of cardiologists who know if they don't send this patient to the right surgeon, they're not going to have a good result. I don't think that those cardiologists are going to want to compromise on that result.
Marty?
And we were just speaking about the volume. In order to do a minimally invasive myectomy, you need a large volume to be able to master that technique. And you're not going to achieve that very easily.
Yep. I think Dr. Martin was going to say something on that.
No, I was gonna just say that I have to leave soon, but I wanted to make a couple just kind of closing comments if I could here. Here's what I'd like to say. I want to first thank you for putting this together. It's hugely important initiative to continue to increase the visibility for this operation. And on that note, the newer drugs and therapies are going to increase surgical volume in the future. Okay, that's what's going to happen here. It's going to increase.
Good point.
And so we need to be prepared, not afraid, prepared to address that issue by increasing the number and level of great cardiac surgeons around the world to give patients the access to this treatment that they need. They're always going to need it. It's a mechanical form of heart failure for which surgery will always play a central role. And as I said, that role is going to only increase now, not the other way around. So this makes this kind of initiative even more important. And what we were discussing in terms of strategies to train the next generation only take on greater priority right now. And that's how I view it.
So great remarks and motivation to keep going on that. So I think it's time for us to close this webinar. as said, would keep going with lots of questions and neat insight from everybody. It's been a pleasure. Thank you all for contributing, for those that could be here today in this webinar, and also for the contributors that could not join at the end. We really thank our colleagues on the roundtable, Juan Grau, Pietro Bayona, Cristina Ibanez, Carlos Mestres, very instrumental in the last lecture, Harzal Schaaf, Jody Rainey, and the guys from Lyon, also Jean-Francois Abadia on his lecture. So the ones missing, we really are thankful to you. And also thank you very much, CTSNet and all the people watching. We hope we can repeat something like this in the future in this disease. Clearly, we need more time on that. So we're eager to take any challenges in this aspect. So thank you very much.
Thank you.
And thanks for joining.
Thank you very much. Great webinar.
Thank you.
Thanks.
Thank you for attending the CTSNet webinar. You can check out Edward's full guest editor series on operative management of hypertrophic obstructive cardiomyopathy at ctsnet.org, along with hundreds of additional cardiothoracic surgery videos. As a reminder, a recording of today's webinar will be available next Monday on ctsnet.org and CTSNet's YouTube channel. To stay up to date with the latest CTSNet content and be an active part of the online global cardiothoracic community, be sure to create or update your CTSNet profile today. Thank you.
Thank you very much.